Okay, welcome everybody back. People are still coming in from the break. That was a great first session. Thank you much to the live centers as well. And for the next session, we'll be focusing on esophageal motility, achalasia. And I just want to say that for all of the presentations, they're available on the website so you can actually see them. So some of the presentations we may not be able to see full amounts if we have to switch to live courses. So for late session, that's going to be part of them, but you can definitely go online and see it. It's my pleasure now to introduce Dr. Rena Yadlapati. Rena is part of our faculty here at UC San Diego. She's really become one of the experts in not just the country and the world in terms of achalasia, especially the diagnosis and the evaluation. So Rena, thanks for joining. Appreciate you being here.
Well, good morning, everybody. Thank you, Tom, for that very kind introduction. And gosh, it is such a pleasure to be in person. I've been looking forward to this for quite some time. So thank you to the SCSG. I will be talking about utilizing the functional lumen imaging probe, or FLIP, in clinical practice. Can I get my slides back? All right, perfect, thank you. Okay, so before we talk about the clinical utility of FLIP, I wanted to spend just one slide talking about esophageal peristalsis because it's very important to have a foundation of where we're coming from in terms of primary and secondary peristalsis to understand how FLIP really works. So as all of you know, swallowing is really our primary mechanism of peristalsis, which leads to deglutitive relaxation of the lower esophageal sphincter and a sophisticated, coordinated peristaltic activity in the esophageal body. And this is what is leveraged by high-resolution manometry when we study motility in patients with manometry. However, secondary peristalsis is also very important, and this is peristalsis in the esophageal body in response to distension. So this could be refluxate or retained bolus in the esophagus. And this is what's leveraged by FLIP. So as we talk about FLIP, you'll see that with FLIP, there is a sustained volumetric distension in the esophagus, and it assesses the properties proximal to this distension. So what is FLIP? This is a picture of FLIP version 1.0. This is what I started working with when I was at Northwestern in 2013, actually with my mentor who's really pioneered a lot of this work, John Pandolfino. He's going to be talking tomorrow about esophageal physiology. So the FLIP system is connected to a catheter that has 16 impedance sensors and a single pressure sensor. And these are all surrounded by a balloon. So when the catheter is placed, typically during a sedated upper endoscopy, it's transorally placed, and the goal is for the catheter to traverse the esophagogastric junction, have a couple sensors in the stomach, and then the balloon is filled, and there's a mechanical pump in the FLIP system that fills the balloon. So when the balloon is filled, the impedance sensors are able to measure a diameter, or cross-sectional area, and then we get a distensive pressure. The relationship of the cross-sectional area over the pressure yields a distensibility index. And one of the primary metrics that we've been interested in is the distensibility index across the esophagogastric junction. Now, what's been really amazing is the evolution of FLIP. So I showed you that version 1.0, that was a 3D rendering of the esophagus. Now we have FLIP with topography, also known as FLIP panometry. So this is kind of akin to what we see with high-resolution manometry, where on the x-axis is time, and the y-axis is the esophageal body. So now in real time, when we're performing FLIP, we can appreciate these properties on a continuum of time. So what you're seeing here is the esophagogastric junction. You see as the balloon is filled, the black turns into green and blue. So the warmer black colors represent a small diameter. The green-blue colors represent a larger diameter. So as that balloon is filled, the EGJ is opening. And then you also see that there's activity above it, and that is actually contractile activity in response to the distension. So if we take a closer look, this is something you might see in a patient that you're doing FLIP. You again see that the esophagogastric junction is opening, you're seeing the blue, and then there are these repetitive contractions that are moving in an antigrade fashion. This is what we call racks. You might see this pattern on FLIP in a patient that has this manometry, where in response to swallowing, there's beautiful esophageal peristalsis and the LES relaxes. There's been a lot of work done to understand what is the relevance of this rack pattern. And this data comes from Dusty Carlson and John Pandolfino in the Northwestern group. They developed a rule of 6, and it's actually really neat. So the rule of 6 is that there are 6 consecutive antigrade contractions that are at least 6 centimeters in length, and they occur at about 6 plus or minus 3 per minute. So they looked at this rule of 6 first in 20 asymptomatic controls. 19 out of 20 met this rule of 6. But what was even more interesting is that in 140 patients with achalasia, none of them had this rule of 6. So if you perform a FLIP and you see this and you have no other reason to think that your patient has achalasia, you can really have high confidence that they have a normal FLIP study. They may not need further evaluation for achalasia. There are some other interesting patterns that we see on FLIP too. So on this slide, the FLIP is on the bottom and manometry is on the top. So in patients that have achalasia, on FLIP, we'll often see absence of contractile activity, as you can see here. And you see again that distensibility index remains black and red, so it's not opening up. Sometimes in patients with type 2 achalasia, we'll see some disordered contractile activity. And then you can also appreciate some spastic reactive patterns. So in some cases, we'll see these repetitive contractions, but they're moving retrograde rather than antigrade. These are RRCs. Or sometimes, if any of you have used FLIP, you'll feel the esophagus shortening. You'll feel a really strong occluding contraction. So we refer to these as strong occluding contractions. These are patterns that we see in patients with hypercontractile esophagus, distal esophageal spasm, or type 3 achalasia. So oftentimes people say, well, what's the reliability or relationship between what we see on manometry and FLIP? This was a really great study, again, by Dusty Carlson and John Pandolfino. They had 145 patients with dysphagia. All of them underwent manometry. So 77% had an abnormal manometry. FLIP called 95% of these abnormal as well, and importantly, identified 100% of those that had achalasia as having an abnormal FLIP. So once again, FLIP is very effective at identifying major pathology. But what else was interesting is that FLIP identified 5% of abnormal manometry as normal. And when they looked back at who these 5% were, these were patients that had EGJ outflow obstruction on manometry. Now, we know that patients with EGJ outflow obstruction sometimes do not have true LES dysfunction. It could be from a hiatal hernia or an artifact, and that's, in fact, what was the case here. So we're learning that FLIP can be very helpful when we have equivocal or indeterminate findings on manometry. Now, if we look at patients with a normal manometry, 23%, FLIP called 50% as normal and 50% as abnormal, so there was fair disagreement there. And there's a lot of research going on right now to see, is FLIP detecting some functional abnormalities that maybe manometry is not picking up on? Okay, so I'm going to switch gears a little bit to the protocol and how we actually utilize this in clinical practice. It's important to be aware that there are two catheters, the 325 and the 322. I almost exclusively use the 322 because it's the longer balloon, 16 centimeters, and so we're able to assess the esophageal body and the esophagogastric junction. Oftentimes, my surgical colleagues will use the 325 because it's 8 centimeters, it's shorter, so it gives you a little bit of a higher resolution at the esophagogastric junction. So the protocol for the catheter is at first it's filled to 30 milliliters. At 30, we ensure that we're in the correct location. We like to see that nice waist. And then we fill to 40, 50, 60. And at each of these, you wait about 60 seconds at least to allow for normalization of the patterns, and then fill to 70. Nowadays, we've been talking about there might be some value in going back to 60 after the 70 to see if there are any changes, and you'll probably be hearing more about this in the coming year. So once you've filled at each of these, you look at the distensibility index, the diameter across the EGJ, the pressure, and then what the contractile pattern is. Then putting it all together. So if you do a FLIP study, and most of the normative data we have is at 60 milliliters fill. So at 60 milliliters, if you have a distensibility index that's over 3, an EGJ diameter over 18, and those repetitive antigrade contractions, that's a normal FLIP study. On the other hand, if the EGJ distensibility index is less than 2, the diameter is less than 13, or you see those repetitive retrograde contractions, occluding contractions, or there's no contractility, that's abnormal. And certainly if the distensibility index is less than 2, that should raise suspicion for achalasia or an outflow obstructive process. And then there's this gray area, certainly. So I wanted to present a few cases to really highlight how FLIP plays into our clinical practice. The first one is of a 65-year-old woman that had dysphagia for 2 years, dysphagia to solids and liquids. It was progressive. She also had a tremendous amount of other esophageal symptoms, regurgitation, cough, throat burning, retrosternal chest pain, heartburn that was partially responsive to PPIs. So her differential was broad, but there was high concern for achalasia or major motor pathology. She was first seen by my colleague who did an upper endoscopy, and you can see that her esophagus is dilated. There's some retained fluid and pills. There's also white plaques, and on biopsy was consistent with Candida. But interestingly, he had no difficulty in traversing the LES at all. And on retroflexion, there was no pericardial mass. The gastroesophageal flap valve was a grade 1. So he astutely ordered a high-resolution manometry, and this is one representative swallow. So you can see that with swallowing, there's failed peristalsis, but that IRP, the LES relaxation pressure, was in the normal range. It was 10.5 across all of the swallows. So if we look at our Chicago classification, which is now in version 4.0, technically this meets criteria for absent contractility, but it's really important to note that if you suspect that a patient has achalasia and their IRPs are in that borderline upper limit of normal range, you should rule out achalasia. And certainly in her case, given her symptoms and her endoscopy, that was a concern. So we performed a FLIP, and this is what we see in real time when we do FLIP. So, again, the x-axis is time, y-axis is esophageal length or catheter, and this is at the 60 milliliter fill. And you can see at the bottom that that is just staying red, right? That EGJ distensibility index is around 1, and it's not opening. And the diameter across the EGJ, 4.7. And there's complete absence of a contractile pattern in the esophageal body. So we did this. We also got a barium esophagram, but this was certainly consistent with a type 1 achalasia, and she ended up getting a lapeller myotomy with the door fundoplication. So now I'm going to switch gears to a completely different case. This is a 35-year-old man who presented with chest pain with meals and at bedtime. It was determined to be non-cardiac. He also had some mild heartburn, partially responsive to PPIs, very vigorous, frequent belching, and then intermittent dysphagia to solids. And interestingly, in his history, he had some atopic disease and also autoimmune pathology. So he truly had a broad differential, anywhere from GERD, EOE, maybe a functional disorder. So for him, we started with an upper endoscopy, and his is very different than our last patient. Beautiful esophageal mucosa, healthy vasculature, biopsies are negative for EOE, normal esophagogastric junction, gastroesophageal flap valve 1, no hiatal hernia. So because he had had dysphagia, we did perform FLIP. And here you can see that he has that lovely repetitive antigrade contraction. He meets the rule of 6. His EGJ distensibility index was 5.4, which is normal. His diameters were well above 18. So he had a normal FLIP study. We also had decided beforehand that if everything looked normal, then we would do a wireless pH study. And our protocol is to do 96 hours off PPI. So he had a prolonged wireless study. His total acid exposure was about 2.2%, well below 4%. It was normal every single day of the study. And he did have an association with reflux with belching. So in one visit, we were able to tell him, you don't have a mechanical etiology of your symptoms, don't have EOE, GERD, and we have very high confidence that your motility is preserved. We suspected a functional esophageal disorder and supragastric belching. And so we counseled him extensively on breathing exercises. We started amitriptyline and referred him to a hypnotherapist, stopped his PPIs. And I just saw him recently. He's actually had 75% improvement of his symptoms, and he's doing remarkably well. And if he hadn't had an improvement, we could have still done postprandial manometry or pH impedance, so we still have these other tools available to us. Okay, and then my last case. So this is a 46-year-old woman with dysphagia, regurgitation, chest pain, weight loss. My colleague at an outside hospital did an endoscopy. There was a dilated esophagus, and he thought there was a hypertonic LES. So we were, of course, all concerned about achalasia. She was referred to our center, and on manometry, you see that she has failed peristalsis, but certainly has pan-esophageal pressurization. The IRP, the LES relaxation pressures are elevated. So again, if we look at our Chicago classification, she meets criteria for type 2 achalasia. So we offered her the three first-line options, which are POEM, lapellar myotomy, and pneumatic dilation, and she was very interested in POEM. So our protocol is to do a FLIP prior to the POEM, and in her case, her distensibility index was 2.4, which is in that borderline range. Her diameters were 9.2, which is abnormal, and she had absent contractile response to distension, so consistent with achalasia. She underwent a 7-centimeter anterior POEM with Dr. Femi, who's actually going to be speaking a little bit later today. And then our protocol is that before he closes the mucosotomy, we perform another FLIP, just to ensure that he's satisfied with the myotomy, he knows that it's complete. And this is what her post-POEM FLIP showed. The distensibility index was 5.4, which is right where we hope or anticipate the DIs to be. So he closed the mucosotomy. We recently saw her for 12-month follow-up, and on FLIP, her DIs are still around 5.5, 5.6, and she's doing really well. So as far as utilizing FLIP in clinical practice, if you have a patient that you suspect has an esophageal disorder, certainly upper GI endoscopy is still that gateway to really evaluating for a multitude of different pathologies. You can see if the patient has erosive reflux disease or stricture and treat as indicated. Certainly if you suspect EOE, then biopsy. And this is where FLIP has come into my practice. If I suspect an esophageal motor disorder, especially if I think that their motility is going to be normal, or on the other end, they're going to absolutely have an abnormal motility, I will do a FLIP. And if it confirms that the patient does have achalasia or a spastic disorder, it gives me the opportunity to intervene in real time. So whether that's a dilation or Botox. And then if there's a possibility of GERD, we can do wireless pH monitoring off PPI. So really, where FLIP plays a role is it's really helped to streamline patient evaluation in one session. So you're able to assess for all of these pathologies, the potential to treat in real time, and probably the most important, which is about 30% of my patients, is that when all of these tests are normal, we can easily go to functional esophageal disorder and streamline their care rather than them getting another test after another test and so forth. And then, of course, you're not burning any bridges. We still have manometry or barium esophagram if they can help. And then the other area that FLIP is very helpful is it's in a very important supportive tool. So we've talked about how it can help assess the EGJ distensibility when you have indeterminate or equivocal findings on manometry. And then also it can really help tailor your intervention, whether it's a myotomy or an anti-reflux intervention. So with that, I will end, and I thank you so much for your attention and the invitation to speak today. Thank you.
Thanks, Rena, for that